Thanks everybody for joining. So promptly, we're just going to admit everybody and we're going to probably make a start at 1 or 2 minutes past. It's so nice to see so many people here. Bang on 12. We've got all of our speakers here, which is great. And we will be ready to roll in a second. I think from looking at the list as well, it's quite nice. This is part of a webinar series that I'll introduce shortly, but it's lots of new names on the list as well. So nice to see all the people who we haven't seen at previous webinars as well. Okie doke. I think I'm going to make a start just to make sure we've got plenty of time for the presentation and then a Q&A at the end. So we're already recording, I think, Jamie, so I'll kick us off. So welcome everybody to our third webinar today as part of our real world evaluation webinar series. My name's Ruth Barker and I'm the Senior Insights Manager at Health Innovation West of England. Today we'll be focusing on impact evaluation, and the presentation part of this will be led by Mairead Murphy, who's the Associate Director of Evaluation and Insights here at West of England. Mairead can introduce herself when she starts her presentation a bit more. I will probably not do her background justice by trying to introduce her on her behalf. We've also just a big thanks to Jamie, who is our Project Support Officer in the Evaluation and Insights team, who has been so helpful in the background of getting all this set up. So as I say, starting the webinar, just to give people a bit of a background about who we are as a health innovation network and what health innovation networks are. So there are 15 health innovation networks across England. We operate as the key innovation arm of the NHS. We collectively aim to spread and scale innovation at pace, aiming to improve and transform lives and generating economic growth for innovators. And as part of the work that we do within the West of England, we've got obviously evolving and changing boundaries of where we work. But you can see from the graph, from the map, where we kind of focus our work within the West of England. I'm not going to go into lots of detail today about the programmes and the work that we do within the West of England, but please do go to the website and have a look at our case studies to find information and any resources or events that we do within Health Innovation West of England. So for those who have joined us previously, you will probably recognise this slide. So this webinar series is focusing on answering 3 key questions. So in terms of real world evaluation, does an innovation work? Thinking about that from an impact evaluation perspective. Why and how does innovation work? And that's thinking about it as process evaluation, and then is it worth it? So from an economic perspective. And this is really thinking about these questions in this real world environment that we work in when we work it from an evaluation perspective. So the previous webinars in the webinar series, if you're interested in going back to look at those, we did an introduction to real world evaluation back in December, and we reran that early February this year. So there is a recording of that, and that introduces process, impact and economic evaluation, so it gives people a starting point if you want to go and go back to that session. We then did a follow-on session which was on implementation economics and health economics. Again, we've got a recording of that should anybody want to go back and have a look at that specifically in more detail. We do have the final upcoming webinar of this webinar series, which will be looking at process evaluation. That's coming up in September. So again, if you were interested in learning more about process evaluation, please do follow the link that will be in the chat to book your place on that webinar. So as I said, today is the webinar in this webinar series that's focusing on impact evaluation, and we would really like just to check before we start this webinar kind of, I guess, how confident people feel about impact evaluation. So on a scale of 1 to 10, 1 being not confident at all and 10 feeling very confident, how confident are you? And answering on that same comment, if people are happy to pop in the chat, you know, what would you like to get out of the session today on impact evaluation? That'll just help us in terms of how we direct the content today. So I'll give people a second to pop in the chat a response to that. I have the chat open, I can't see any typing, but that might just be my chat. Super. What I'll do is I've got a couple of people coming in now. Lovely. So I've got a 7 out of 10, moderately confident, another 7 out of 10. So a couple of people. So I think we've got people who probably have a background, have an understanding, but might be here to get that level of detail. 5 out of 10, 6 out of 10. Interested to know about different approaches. Hopefully we'll cover that in the evaluation. Maire's got a fantastic set of slides on how to think about this. How to evaluate complex projects. 8 out of 10, 5 out of 10, fabulous. So we've got a bit of a range. We will do a Q&A at the end, so please do use the chat as well as we go to pop questions into the chat, and at the end of the presentation we'll pick up on those questions. So in terms of the session today, we're hoping to begin to answer this question. So how best to generate evidence through real world evaluation that is high quality and robust, that demonstrates whether your innovation works. So really today we're talking about evaluation and not research. We're not talking about clinical trials of medicinal products, and we're not talking about randomized control trials here. We are talking about evaluation and in this real world pragmatic setting. And this will hopefully start to answer this question, get some cogs whirring, and hopefully give you a starting point to think about designing and delivering your own impact evaluations. So I'm going to hand over to Mairead to introduce herself and start the presentation on impact evaluation.
Thanks, Ruth, for that introduction. So yeah, like Ruth said, I'm the AD, Associate Director of Evaluation and Insights at Health Innovation West of England. And great to see in the chat all your experience. I'm seeing about a 6 to 7 out of 10 there, and a desire to know more, which is a great place to be. I think I'm just going to get straight into the session on what do we mean by impact evaluation. So impact evaluation answers the question, what changed because of this intervention? And you'll see there's 2 sides to that sentence. There's firstly the what changed, and there's secondly the because of this intervention. Now, in terms of the what, a really important starting point of impact evaluation is to focus on that what. So to focus on what you can influence. And that means really trying to understand the problem, the population, and the theory of change before you proceed to measurement. And then in terms of the second part of that sentence, because of this intervention, that's probably where it gets a bit tricky. Because to know that something happened because of an intervention, then that's where you're attributing causality, and you need to know what would have happened anyway. And that's sometimes called the counterfactual, which is a term I'm going to use a bit in this presentation. Now, you might recognize the scene from Back to the Future here. I haven't just put this here because of my childhood love of Michael J. Fox, but also because of the time travel reference. Because unlike Marty and Doc, we don't have a time machine, so we can actually never know for certain what would have happened anyway. And that's where we use design and analysis to estimate that, and that's a core part of impact evaluation. So that's impact evaluation in a nutshell. Now, how do you go about doing it? I can see in the chat a lot of people want to know this. We've broken it down for this presentation purposes into 4 stages: planning, designing, delivery, and use. There's a lot on this slide, so let's step through these one by one. So planning, let's start with planning. Now, planning is about making a small number of of critical decisions up front that will shape everything that follows. So the first thing you'll see here is to clarify the purpose and the audience. Because any kind of evidence is only going to make sense in relation to who needs it and in relation to what decisions it's meant to inform. The cartoon here is obviously light-hearted, it's a joke, but having said that, it happens surprisingly often. Just as an example, let me tell you about a hugely innovative, inspiring, smart health professional, really innovative, I met last month. And they designed something really exciting that had promised to help patient flow and patient experience through the hospital. But when I asked them, what's the impact evaluation for? They were asking for my support with designing an impact evaluation. They really struggled to answer that question. So the chief nurse had asked them for more evidence, but hadn't told them what evidence would get them commissioned, or even if they would commission it if they had more evidence. So they were about to embark on an evaluation without really knowing what it was going to be used for. So don't do that. And know that evidence aimed at a local commissioner will differ from a policymaker, it will differ from NICE in the outcomes of interest, and the level of confidence required and what counts as acceptable data will differ depending on the innovation, depending on the level of risk. There are evidence standards for digital that you can consult, and we can share the links for those. But actually, in some cases, the standard needs to be established through a discussion. Then as part of that planning phase, you'll need to articulate the problem statement. That will need to be quantified and grounded in evidence. So if you don't, you need to quantify the problem statement because that will help you understand at that very early stage what scale of change is plausible, which populations you're looking at, and then it will all inform those downstream decisions like sample size and comparison groups and what a meaningful effect will look like. Then you need to understand the solution and the pathway map. So how does your solution to the problem fit into or change the pathway? And, you know, you might know this already. If you're an innovator, you might know this. If you're a healthcare professional, you might know this. But your evaluator needs to understand this as well, because they need to build an understanding of how an innovation works in practice to know how it's expected to lead to change. To be able to measure that change, if that makes sense. And then based on that understanding, you can agree the overall scope, size and approach, and broadly establish whether the evaluation is possible to do, whether it's valuable. And then finally, that will be aligned with funding, costing and team capacity. Now, if you're setting out to evaluate something, there was someone put in the chat that they wanted to know how to start. This is how you should start. These sort of activities should drive some of the first questions you ask. So you should be asking, what's this evaluation for? What problem is the innovation trying to solve? Where is the evidence and quantification of that problem? How does the solution change the pathway? What's the scope? And for smaller evaluations, that might happen all quite quickly over a few conversations, but it does need to happen. It shouldn't be skipped. So that is planning. Now on to design. Now, for me, design is the most critical part of the whole process. And so I've got a few slides in design and I'm going to step through them. The cartoon here shows the cat playing the fiddle and then the cow jumping over the moon. And they're looking at it, realizing that one happened after the other, but questioning whether it was causal or not. And this is why design is so important and really why you need to start with a theory of change, knowing what caused or what might plausibly cause another thing. So let's look at that. I think from the scores in the chat, you will have all heard of theory of change. Some of the more beady-eyed of you might have noticed that the Magenta book, so the government guidance and evaluation, was updated a couple of weeks ago. And they put theory of change really front and central in that and made it quite explicit. which I was pleased to see. And a good theory of change will start with the problem statement. Like I said previously, important that this is quantified and evidenced. Then a lot of people will use logic models as their theory of change. So that's absolutely appropriate. It's one way of doing it that articulates how the solution is expected to lead to change by linking the problem, the solution, the activities, and the outcomes and impacts. And it makes the assumptions connecting those explicit rather than implicit, and gives something then to test through the evaluation. Because we're focusing on impact evaluation today, let's look at how to evaluate outcomes and impacts from the logic model. In the examples I've put here, I think it is important to recognise that patient access and experience, as well as clinical and behavioural outcomes, are all important to measure in an impact evaluation. So measures like who is accessing the intervention, how are people moving through it, what are the patterns of use, is there equity of access, is there sustained engagement over time, that's all important to capture. And then from the logic model, we'll develop a measurement framework, which is a high level one is shown here on the slide at the bottom. So that measures, like for each outcome, what measure are we going to use to assess that? What indicator will capture that measure? What's the data source? Is there a baseline? Is there a comparator? It's a really deceptively simple table I've put here that needs to capture some quite complex decisions. So you should be going into this with an overall design in mind, but it's often at this stage when you're putting down outcomes and indicators and they're getting quite specific that you will realise where baseline data or repeated measures or comparators are genuinely needed. And you'll need to start to identify how you're going to analyse that. And then all of that will get written up into an evaluation protocol. Now, this is a really important document. It will underpin your whole evaluation. And a lot of you may know, for NIHR funded research, the protocol has to be published in advance. And that's to be transparent and to help selective reporting. And there is an increasing call for that in real world evaluation as well as research. So that is the theory of change. I said you go into it with a kind of overall design. Let's talk a bit about different kinds of overall design. This is your classic hierarchy of evidence, and it shows how confidence in causal claims will generally increase as you move up the pyramid. So at the top, number 1 and 2, we have randomized control trials and meta-analysis of randomized control trials. These give really, when they're well designed, give the strongest basis for causality, for being able to say that something caused an outcome. Like Ruth said at the beginning, we don't do randomized controlled trials at HINS. We don't do research. They will always be done under a research framework, because they are at their essence experimental. You're conducting an experiment through a randomized controlled trial. But then just below that, at number 3, we have quasi-experimental studies. So these will still aim to estimate, impact. So they still aim to say something about causality, but they rely on constructing that comparison group, or what I call the counterfactual, rather than random assignment. And that's why they're quasi-experimental. There's no experiment. We're trying to recreate the conditions of an experiment through the analysis. And then below that, we have observational studies like cohort, case control, or cross-sectional. Some of you might have heard these terms. Some of you mightn't. They're courses within themselves, but I put them in to give you examples and to emphasize that these can show change, but they are more limited in establishing causality when they're taken as a single and a standalone method. But in practice, impact evaluations don't normally rely on a single method, particularly the way we do them in health innovation networks. We're often combining approaches. So we might be using observational data alongside a theory-based approach, or we might be using evidence from randomized controlled trials from the literature to build a more complete picture of impact. And we do end up doing that quite frequently. So this pyramid is a guide and something for you to be aware of, but a good impact evaluation might be about using multiple sources of evidence to strengthen the conclusions. And that's the reality we often find ourselves in, and the space we often sit in. We're often triangulating primary collected data using one or more of these designs with previous published evaluations. I want to do something a bit differently now and talk about the types of data collection you might do for these different designs. And if we drill into the research hierarchy there at levels 3 and 4 and think about that real world evaluation, be it quasi-experimental or observational, and keeping in mind that question of trying to understand what would have happened anyway, the counterfactual, you could say that most designs, or some designs, because it won't be all, fall into 4 broad options based on kind of 2 questions. So first, how many data points do we capture in our intervention group? The most basic is kind of capturing 1 data point post-implementation. And then the second option is multiple points, which could be just 2 pre-post, or it could be change over time. And then the second thing to consider is, are we just considering our intervention group, or are we also considering a comparator group? So if we look at these 4, the simplest design is post-implementation only, so just in the intervention group. And what that looks like is collecting feedback or outcome data after an innovation or an intervention has been introduced. We'd often do that through surveys or potentially through routine data, but often through surveys. It's really useful for getting experience data, access data, and for sense checking impact. It tells us less about whether there was a genuine change or a perceived change, but we shouldn't completely dismiss it. If you have like a large sample, if you have a very complete sample, and if you can corroborate this with other sources of evidence, it can actually be quite powerful. I'm thinking of an example that we recently supported. One of my colleagues who's on the line helped me support an evaluation for a charity that provides a neighbourhood model of community health, where community health coaches act as trusted facilitators between healthcare systems and underserved populations. And they wanted to see if there had been a reduction in healthcare service use, so in ED appointments and GP use. But they had limited time, they had limited budget. So to evaluate this, they surveyed everyone. They surveyed everyone who'd used their service, and they asked them, what would you have done had this service not been in place? And then they analysed that using PSSRU unit costs, and it showed a reduction in GP appointments and ED attendance. Now, of course, it would have been more robust to do that with a comparator group, but the evidence they had was sufficient to get what was, quite impactful and very low risk intervention. It was sufficient to get that recommissioned by the ICB. The ICB were really quite convinced by the fact that they had a very large sample size and that they were able to look within the group to look for differential outcomes or inequalities. So it's just to give you an example of where that might work, and that might work well. A step further than that will involve collecting a baseline or a series of baseline points to measure change over time in the same group. And then that will be, of course, followed by one or more data points post-implementation. What that does is that lets you look at whether the change is actually a real one, not just a perceived one. But of course, it can't rule out other influences on that change. It might not have been the intervention that caused the change. And this is where you need to pull on qualitative evidence and really understanding that theory of change and looking at what else has been happening. And if you do that, it definitely gives stronger evidence than post-implementation data alone. So it depends on the circumstances whether this is good evidence or not. If there is a very stable baseline and no other interventions, if you combine it with other qualitative data, it could be good and useful evidence. And probably the most common use of this is something like your statistical process control charts that you'll see in QI work, where there is, particularly if there's a sustained baseline over time, or if there's a health condition that tends to be very stable and you look at a pre-post analysis. I say it's simple. It can still get complex quite quickly, and you will have a more robust analysis if you adjust for other variables. So you may need to use what some of you may heard of, like regression analysis, to adjust for differences in differences over time. Or if it is what we call, if it's a sample across, say, GP practices, there are techniques to say that it is clustered by GP practice. And again, I don't expect you to understand all these terms, but it's just to say this type of analysis can be quite simple, or you can add layers of complexity on top of it to make it more robust and accurate. Then you've got a third option, which is a post-implementation measurement with a comparator. So comparing outcomes in a service using an innovation with a similar service that isn't. And it can strengthen confidence in reducing that comparison. And you'll notice there's no baseline in this, but that might be entirely appropriate for interventions where baseline just doesn't conceptually exist. So an outcome like that might be death, which only happens once, or maternity outcomes. So another example for you, we recently evaluated the clinical outcomes of a device that was designed to improve repair of tears during childbirth. It was called the Hegenberger retractor. And then we compared the outcomes. So the outcomes we were looking at were surgical time and postpartum incontinence and a few other clinical measures. We compared them in our group where the Hegenberger retractor was used with another group that didn't use the Hegenberger retractor. And then again, we did a sort of simple comparison, and then we extended the analysis so that we could adjust for some different factors between the groups, like, different gestation levels and different ages and ethnicity. And there are other different forms of analysis that you can do depending on your outcome data. Is it binary? Is it continuous? Is it count? So you might want to consult with evaluators before at the design stage when you're doing that. And then finally, the strongest of the designs is change over time and includes a comparator. So that would be before and after outcomes in the intervention group, with outcomes over the same period in a group that didn't receive the innovation. So this is a really kind of strong design that provides greater confidence about attribution. But we don't actually get the opportunity to do this very much, particularly in smaller evaluations. It requires much more planning. It requires greater levels of data access and IG and more resource intensive work. So the kind of analysis methods you may have heard of that use this kind of data collection design, it'll depend on the structure of the data, but it can include difference in difference analysis or propensity score matching. But importantly, for any of these, going right back to the first slide on theory of change, deciding on what data collection and what analysis method you use just requires that really thorough understanding of the problem, the solution, the pathway, and the theory of change. So evaluators need to be involved in all of those things. And also to say, these aren't the only 4 options. They're just some of the many design choices you have to make as an evaluator, but I'm including them all at this stage just to show how much thinking needs to go in at that design stage. And it's also important to say that different outcomes within the same measurement framework and within the same evaluation can sit in different parts of this space. And in an impact evaluation journey, it is reasonable to start at the top left and to work on getting an analysis of your cohort, their experience, their access, their engagement, and their perceived outcomes, and to focus really hard on getting a complete data set with a representative large sample, but working towards a more rigorous study. And the other thing that's perfectly rigorous and all right to do as well is, remember, if you already have good RCT or quasi-experimental evidence for an intervention, you don't need to repeat that level of impact evaluation every time you redeploy somewhere else. If you're asked for a local impact evaluation, you can focus on continued measurements of engagement, experience, and you can model the impact from previous studies, because this type of quasi-experimental study, or this kind of large scale where you're measuring comparator over time before and after, it's complex and it's expensive. So you just need to have those conversations with your commissioners to design something that is proportionate and not to reinvent the wheel, to make sure that you are doing that literature review and seeing what evidence is out there before you embark on an evaluation. So that was design. I said I was going to spend most of the time on design. I know there was a lot in there, but I hope hopefully it's given food for thought. Delivery. So I said design was the most important, but actually it will be much shorter than delivery. Delivery could be anything between a few months to years, depending on how long an intervention period is. And delivery is really about putting the design into practice and doing that responsibly and pragmatically. We're talking about impact evaluation today, but in practice, you will probably be delivering this alongside a process evaluation. And that is because the real world is messy. We all know that. And you generally need to do both together to really understand what's going on and to be able to get under the skin of the findings from your quantitative data. Because it's messy and because you need to understand that, you will need to work with people while you're doing it, with implementers, with users, with clinicians. The cartoon here captures the kind of ivory tower that sometimes evaluators are accused of sitting in. And there can be a belief that to maintain independence, you need to sit very separately and keep all your findings private until you're ready to publish them. And that, I learned that wasn't correct quite early on in my career. Actually, I was involved in evaluating community frailty service. And early on, it looked like hospital admissions had increased, which was actually the opposite to what people had expected. So I flagged it to a clinician, and the clinician explained to me, well, we're not seeing the same patients anymore. We're taking on more complex cases, and I suspect that's why you're seeing this. So then I went back and I looked at the descriptive data to see if they were correct, and they actually were. The caseload had shifted towards higher risk, older patients. So what that meant was that I had to do a slightly different form of analysis. I couldn't just do a simple comparison. I had to adjust for that in a regression analysis. And once I adjusted for that, that increase largely disappeared. So if I had waited until publication, those findings just wouldn't have had any credibility with the people using them, because they wouldn't have been correct. So yeah, always consult during delivery with the groups of people you're working with. And the process here describes it at a high level what needs to be done, but things that you can't forget. So it will start with data protection and governance, sorry. So DPIAs, data processing impact assessments, and data sharing agreements. These can feel sort of a bit tedious and administrative, but they are a legal necessity in some cases. They can be done quickly, but they can also take a long time, especially if you're using routine data for a comparator rather than collecting your own. And if you have multiple sites rather than a single site, this becomes, much more time consuming, because you're dealing with 10 DPIAs if you've got 10 sites rather than one DPIA. And then alongside that sits governance and ethics. Again, scaled to the risk and sensitivity of the evaluation. Even if you don't need formal ethics, you do need to give proportionate attention to consent and confidentiality and governance structures. Data collection and analysis, I will say this is always underestimated, again, especially if it's routine data rather than survey data. You have a bit more control over, but for routine data, you will need to chase it. You will need to check completeness, resolve inconsistencies, really understand how it's been recorded, and make pragmatic decisions about what can and what can't be used, and potentially recollect data. And then the analysis, like I say, is rarely a single linear step. It will be iterative, moving back and forth between the data, the evaluation questions, and discussion with stakeholders. And then interpretation is a critical part of that. These are shown as linear, but actually it's not like you collect data, analyze, then interpret. Interpretation is a critical part of delivery, not an add-on. When you're interpreting the data, you will need to work with people who understand the context. And then it will all culminate in reporting, where the findings are documented clearly and transparently. And it is good practice to publish everything, to publish all evaluations, even if you don't really like the outcomes. Then finally, use. This is why we do evaluation. We do evaluation to use it. This is where it creates value. And it's all too easy to kind of share the evaluation with the commissioner, publish it and move it on. I know I say that because I know I'm guilty of this. There's so much work to do. There's so many more projects to evaluate. But I have to remind myself, this is what we did the evaluation for. Let's squeeze every drop out of it that we can. So this phase is about identifying the key messages from the evaluation and translating them into outputs that matter. And different forms of that might be different for different audiences. We recently did quite a small desk-based evaluation of a unisex urinal called UniWee. It's a urinal that can be used by women and people without male genitalia in hospital. And it showed cost savings of using that. And one thing that's really pleased me is that the evaluation report it's been used by the hospital that asked us to do this, but it's also been used by NHS supply chain to help them persuade other trusts of the benefits. And we hadn't initially envisaged that NHS supply chain would be an audience. So that's an example of why it was important to take that time after publication to think of all the audiences and help them understand and use the key messages. And then importantly, that final stage of use links directly back to the start of the process, because if the purpose and audience were clear during planning, then it will become much easier to ensure that the findings are used at the end, because you'll have that plan in place. So at this point, having talked through planning, design, delivery, and use, the question I'm often asked is, well, Mairead, how much evidence do I need? How much evidence is enough to get my innovation deployed or to get it moved forward? And this slide brings together some kind of key principles to help answer that. Because the first thing to say is there is no one-size-fits-all level of evidence. It will depend on the decisions the evidence is intended to inform. It will depend on who needs to be convinced. So, like, for example, with UniWe that I just spoke about, we needed that cost model. But with the Hegenberger retractor, we needed to understand patient benefit. And actually, one of the most overlooked steps is just to ask commissioners early what level of evidence they need and what type of evidence they need. And it will also depend on the stage of innovation, whether it's early stage or later stage. It will depend on how much evidence you already have. And it will depend on the level of clinical risk, of course, and whether you need to prove patient safety and whether you need to make those strong causal claims. There's guidance available. So NICE has evidence standards for digital that can help you align evaluation efforts with expectations. And you will see in that higher risk technologies have a higher standard for evaluation evidence. And we can share that if you're not aware of it after the webinar. Common challenges and pitfalls. Talking sort of on, well, I think I have probably talked honestly about some of the challenges through this, but kind of to emphasize these, even when a process has been really well planned and designed, there are some common challenges and pitfalls. So complexity, impact evaluations do often go off track, not because the team's done something wrong, but because of real world complexity, because the world evolves around us as we're evaluating, because the implementation timeline changes, and because the data systems don't behave as well as we had hoped. Then another recurring challenge going down the slide is that just that need to make trade-offs between rigor and complexity or feasibility. So stronger designs can increase confidence, but they require more time, more data access, and more resource. So in practice, I mean, the solution to that, though, isn't to do non-rigorous evaluation. In practice, it's about finding the balance and making the trade-offs consciously and being transparent about their implications. I would say another pitfall that I've found is measuring what's easy rather than what matters. So that can lead to, say, a focus on activity or engagement measures without clear links to outcomes. But it can also lead to measuring outcome data that happens to be routinely available, but actually isn't a good proxy for the actual outcome. So an example might be measuring mortality, because you can get mortality data when actually your theory of change has said the impact is going to be on symptoms or patient empowerment. But because you can't get that data, you fall back on what you can get. Then a related pitfall is measuring what commissioners ask for rather than what the innovation can realistically deliver. Now, I did say ask your commissioners what they need, but on the other hand, I see too often where a commissioner is asked for example, evidence of in-year cost reductions, and then the innovator wants to proceed with designing an evaluation that will measure in-year cost reductions, even though all the planning and design work has pointed towards there being no in-year savings. If that is the case, it's much better to have an early discussion about that than persisting with an evaluation that really isn't going to deliver what you're measuring. Underestimating data challenges. Data is frequently more challenging than expected. Access takes longer, and also effort for cleaning and preparation is often underestimated. I mean, they're normal challenges, but we just see them happen so much again and again, that we probably need to start planning for them better. And then partly as a result of all of what we've said, impact evaluations don't always produce clear or unambiguous findings. There's a lovely picture here of an arrow going up in the air, which is all what we want to see with our impact evaluations. But the findings might be mixed, they might be context specific, it might be difficult to attribute it with confidence. And if that is the case, that doesn't automatically mean the innovation or intervention has no value or the evaluation has no value. It's about reporting it transparently and clearly and doing what you can with it, and using it appropriately, so it can still support learning and decision making rather than treating impact as a simple yes or no. So to close, here's a few key messages. Start with purpose and audience. Take time to design. Design proportionately, but also iteratively. Value access and experience as outcome indicators. I have just said that there can be an over-reliance on those, but I do sometimes see people swinging the other way and dismissing these entirely. They are really relevant forms of evidence. And don't forget that equitable access to proven quality of care is an outcome in itself. And also use evaluation to support decisions. Yes, it should be used to prove impact. It is an impact evaluation after all, and to inform commissioning, spread and scale and funding. But even when impact is unclear or mixed, it can inform learning, refinement, and whether to adapt. And then finally, seek advice from the health innovation networks, from us on design, from the RRDN if you're submitting an NIHR application, and from your commissioners on what they want. And my final slide, because I started with Marty, I thought I'd finish with Doc. Not just because things have gone a bit wrong here for Doc, and I said things sometimes can go wrong with impact evaluation, but just to emphasize that impact evaluation is about observing that timeline that we can't see. We don't have time travel, but we do have methods, and it is about using the best combination of those methods to build that credible picture of what likely happened.